It's a familiar image. Aging portrayed with walking frames, hunched postures, and limited mobility. As we move through our 30s, 40s, 50s, and beyond, many of us begin to notice stiff joints, sore muscles, and that creaky feeling when getting up from the sofa. We tend to accept it as just part of getting older. Aches and pains? Inevitable, right? Maybe you've seen older relatives gradually lose their strength, balance, or independence. But do we really understand why our bodies change, or whether it has to be this way? Or can we do more to protect our bones, joints, and muscles? The global health industry spends billions trying to tackle the symptoms caused by worsening bones, muscles, and joints. But what if we focused more on improving our understanding and on prevention? Welcome to Joint Care, a podcast exploring musculoskeletal health through expert insight, clinical evidence, and the real experiences of people, especially women, living with osteoporosis. We're here to spotlight the how and the why of bone and muscle health, and to share practical ways to stay mobile, strong, and independent as we age. This is your front row seat to knowledge that empowers you to take charge of your body. My name is Kemi, and I am your host. I am a GP. Prior to this, I was an orthopedic surgeon in training. I saw firsthand the impact of osteoporosis with fractures, the severe pain and loss of function caused, and the potential to change the course of one's life. I'm joined today by Dr. Adzira Thahal, an experienced consultant radiologist and physician, and an expert in musculoskeletal radiology, which means she can likely name every muscle, tendon, ligament, and bone in the body, and in 3 dimensions. I'm incredibly honored to have her here with me today. We've been personal friends since before we could probably remember. It's just wonderful to have her here today to discuss this important topic. Welcome, Dr. Thahal.
Thank you for having me.
Okay. So first of all, just tell us a bit about what you do and what your job is.
Yes, as you said, I'm a musculoskeletal radiologist. I've been a consultant for almost 10 years now. My specialty is orthopedic radiology, but I'm also a general radiologist. And I look at bones, joints, and have an awareness of all the pathology related to them, and work really closely with orthopedic surgeons, as you will want to.
What does your day job look like, or an average day?
Average day, it's a mixture of reporting x-rays from GPs, from hospital doctors, to reporting CT scans and MRI scans, also from doctors in the hospital and the community. I do some ultrasound scanning of bones, joints, tendons, ligaments, and also do some intervention with that, so injecting them to help to treat conditions like arthritis or inflammation of tendons, and also use x-rays to do some image-guided intervention around nerves for people that might have things like sciatica that causes back and leg pain.
I mean, radiology is one of those specialties that is probably one of the unsung heroes, and the average layperson probably doesn't quite understand, which is why I thought we would start there. You are a doctor, you spent many years training, and you have an incredible depth of knowledge of the human body. I guess it would be good to just ask you some questions to build a picture around bone health. In terms of osteoporosis, you would typically be identifying that on certain types of imaging and scans. What sorts of imaging techniques can be used, or can you see osteoporosis in?
So you can get an idea if someone has osteoporosis right from an x-ray, a simple x-ray. Now, not so much to make the diagnosis. You need up to sort of 30 to 50% loss of bone density to make the diagnosis of osteoporosis on an x-ray. But if you were to do an x-ray and you have the typical type of fracture that we see in osteoporosis, like a fracture of the vertebral body, so a fracture of the spine, or a fracture of your wrist, or around the pelvis, in the back of the pelvis, which is called the sacral ala, or the front of the pelvis, which we have structures called the pubic rami. Those type of fractures are very pathognomonic of osteoporosis and low bone mineral density. So starting with x-rays, if you have a fracture like that, then you should start thinking about it. But to make a formal diagnosis of osteoporosis, that comes from doing a special test called a DEXA scan. So that's a dual energy X-ray absorptiometry scan.
That's quite a
And those
mouthful.
scans, it is. That's why we call it DEXA. Easy. So a DEXA scan is the scan to do to have an official diagnosis of osteoporosis.
It's interesting because so often, in our clinical practice as GPs, and obviously my former job in orthopedics, we would often see quite clearly on an X-ray that the bones didn't look as white as normal on an X-ray, and actually even once the bone's broken, you can see features on a plain X-ray that suggest osteoporosis. So sometimes a fracture will be termed an osteoporotic fracture, even without a formal diagnosis, because it's quite clear to see. It's interesting that you say, by the time you're seeing that on a plain X-ray, you've lost up to half of your bone density. That's quite astounding.
Yeah, it is. It really is. So what you really want, you don't want to get there, and you want to sort of pick this up early enough to stop you from losing so much bone.
Mm-hmm. Okay. What are the key risk factors that would prompt a bone density scan? If a junior doctor came to you and said, "I'd like to have a bone density scan," what reasons would you like them to give you to actually give them the scan?
The first thing is if the patient has a previous history of a fragility fracture. So if they've had the fractures that I said, so even one fracture of the vertebral body, and what I term fragility fractures, because all of these fractures I've said can happen anyway for most people. But what a fragility fracture is a fracture like that has happened secondary to a force that wouldn't normally cause a fracture. So if no one has had trauma, or you've just had a slight little tumble and you've ended up with a fracture of your spine, or fracture of the front or back of your hip, of your pelvic bone or of your hip, then that should start to raise alarm bells that maybe there's osteoporosis. So one, personal history of a fragility fracture. The second thing is any medical conditions. So conditions like rheumatoid arthritis, which can reduce your bone mineral density, or thyroid issues, or some gastrointestinal issues like celiac disease, that can increase your risk. So medical conditions can. Medication also, if the patient has been on long-term steroid therapy, that can also increase your risk. So those sort of things. Obviously, in postmenopausal women, your estrogen levels are low, so that increases your risk as well. And also in men with low testosterone levels. So all of those things together, and thinking about the risk factors, and also heavy alcohol intake can also increase your risk. So those are the things that I'll have a discussion with the referrer to see, okay, do we need to do a bone mineral density scan, a DEXA scan, to see if we have that diagnosis?
Wow, so there's a lot, isn't there, going on that can tell into picture even before you decide whether or not to do a scan. So how does a DEXA scan work, and what actually happens when someone goes for a DEXA scan?
Okay, it's a good question. A DEXA scan is a type of X-ray scan, but the dose of the X-ray is much lower than the standard X-ray. So it's probably up to 30 times lower dose than a standard chest X-ray. So really, really low dose. It's safe. It takes about 5 minutes or so to do, and there's a special table you lie on. It's not a whole enclosed thing. It's very open. So if you're claustrophobic, then I wouldn't worry about it. You're lying in an open space. There's a small sort of shelf type structure that moves over your hip. So there are two areas that generally get scanned. So right over your hip, it will take a low dose X-ray. Then it will move to your abdominal area to get an X-ray of your lower back, your lumbar spine. It will also take another X-ray there. And then that then is just analyzed by the computer to then give a reading, which is called a T-score. Or if you're younger, it's a Z-score that we look at. So that's basically it with the DEXA.
So this was always something to wrap my head around studying for exams, the difference between a T and a Z score. I could try putting myself on the spot now to explain the difference, but this is why we have an expert. So can you tell us the difference between a T score and a Z score, and why is it that we focus more on the T score?
Okay. I can. So a T-score generally it's a measure of bone mineral density compared to a young adult at peak bone mineral density matched for sex. So it's generally young, of the same gender as the patient having the DEXA scan. That's what you're comparing it to. And with a Z score, it's generally matched for age.
Right. Okay.
So T score is comparing yourself to a younger person with peak bone mineral density.
And then the Z score
is someone who is matched to you and your age. And so generally we use a Z score for younger patients. So premenopausal women, younger patients. So it's not very commonly used because we don't tend to do DEXA scans on younger people, but that's when you have a look at the Z score, then to see if it's low, then you need to start doing some other tests to figure out why the density is low.
So
But in general,
if it was me and I was in my youth, let's say I was 29, you would be comparing it to what you would expect my bone density to be at 29.
yes,
Yeah.
that's exactly it. Yeah.
And what do you term young?
So generally, actually, the Z score it tends to be used for premenopausal women, so class that or whatever you want to, or men under the age of 50.
Okay, so
Yeah.
we are still young.
Yes.
There's nothing wrong with being mature and older. It's just we
Yes.
can, cling on
Yeah.
to that title for a bit longer.
Yeah.
It's great revision for me. I was keeping up with you there, so it's not all gone just yet.
Good.
What age would you say as a radiologist? This is a slightly broad question because obviously there's so many factors. At what age would you say that somebody should get screened for osteoporosis? So when do you start to get a sense, looking at the thousands of scans that you've looked at in your time, that there's something going wrong with the bone? We do already know that peak bone density is sort of towards the 30 mark, late 20s, 30. If someone did have some risk factors that you've touched on earlier, when should they, or how often should they be having these scans done?
In the UK, there is no national screening service or provision for osteoporosis detection. But NICE, who are the National Institute for Care and Health Excellence, recommend that clinicians should assess a patient's risk for fractures. So for women, let me get this right, I think it's for women if you're over 65, and if you're men over 75. So that's the first thing. But if you're younger than those ages, if you have risk factors, then then your doctor should be thinking about assessing your risk factor for fracture. So that's just a risk factor for fracture. Now there are different ways you can assess your risk for fracture if you fall into those groups. The DEXA scan is one thing, but you can do it without a DEXA scan actually. And there's a thing called FRAX, which is a score that you get. They'll give you your risk for fracture in over 10 years. Now, you can use the DEXA score as part of the FRAX calculation. It's an online tool that doctors use. You can include DEXA into it, but you can also use FRAX without DEXA, the DEXA score, the T score, to figure out the fracture risk. And as a population, if you're just sitting there watching this and you want to know what your risk factor is, at the Royal Osteoporosis Society have a really useful tool online that you can just go on, and then it asks you a few questions. It takes a couple of minutes and it will tell you what your risk is. So I think that if you know personally that you have a family history, that's a huge one. So if you have a family history of a first degree relative, so a parent or sibling that has had osteoporosis or diagnosis of it, then you are at increased risk regardless of any of the other risk factors. So then, I'd approach your doctor to see if you can get a DEXA scan, and you can also assess your own risk
And
online.
those two things are interlinked, aren't they? So you couldn't be someone with no risk factors and have a significant FRAX score. The
No.
questionnaire actually incorporates these risk factors, and the more of them you have, your age, your family history, certain conditions, certain medication, your smoking habits, those things will altogether paint a picture. So it's actually a very useful tool that's easily accessible. There is another term that's often used, more so in orthopedics, and that's osteopenia. I don't think it's one that the general public are as aware of. Can you explain to us what osteopenia is?
Sure. Osteopenia is a reduction in your bone mineral density, but it's not quite as so bad to call it osteoporosis. So if you just sort of think of it as, you started on that downward trajectory, and if you have that diagnosis, then it's almost a warning shot to, okay, I need to do something about this. Now, if you do have a DEXA scan, one of the readings that you get from it includes osteopenia. So there'll be three things: it'll be normal, osteopenia, or osteoporosis. So it's a useful result to have, because it might give you the wake up call that you need to, do the necessary.
And patients who've had a diagnosis suddenly become very aware, of the scoring, the exact scoring value. And it's a way to measure improvement or deterioration in osteoporosis. So can you just talk to us a little bit about the scores, what they mean, and what sort of ranges would point you towards osteoporosis versus osteopenia versus normal?
So this is referring to the T scores. So T score of greater than or equal to -1 is normal. So that just means if you're -1, you're one standard deviation below your peak at young person specimen of bone mineral density. So -1 or above is normal. Anything between -1 and -2.5 is osteopenia, and anything below -2.5 as a T score is defined as osteoporosis.
It's always a bit difficult, isn't it, and challenging, because we're talking in the minuses. So actually, as the numbers get
Yes,
bigger, things are worse, and we're sort of
going down.
programmed
Yeah,
to think of, oh, I've got a bigger number, great, wonderful. We don't want that
yes.
in osteoporosis. So
So
the
in
ceiling there is
osteoporosis, no.
0, and just
Yes,
below that ceiling, up to -1, we're happy. If you go
yeah,
lower than that ceiling to the -2.5, what you're saying is that's osteopenia, and that's a danger zone.
yes,
And that's
yeah.
your bone is thinning, you're at risk of osteoporosis, but you're not quite there. I'm not sure if there are any radiological guidelines for how often DEXA scans are repeated. In general practice, we often get the report and we'll get a recommendation to repeat it in 3 years' time, 4 years' time. And there doesn't seem to be any rhyme or reason. Or from this side of the fence, it doesn't seem. So is
Yeah.
there any particular guideline that dictates how often and when it should be repeated and what interval? I imagine patients are quite anxious, and actually, if they could, they'd probably say, well, can I just have it in 6 months' time to know sooner than wait 2 years or
Yeah.
3 years?
In general, these scans are repeated to every 3 years afterwards. It's best to wait, really, because you need to give, especially if you're treating, bone needs time to form. And so you just need to actually get a good idea of what's happening. It's good to give it a good interval. Now, for some patients, and that's why there's no one size fits all for this. So if you have quite severe osteoporosis, or you have, multiple risk factors, or depending on the medication that you're on, you might need to have your bone density scan repeated earlier. So it's all really playing it by ear. In general, 2 to 3 years, but some people might need to have it sooner based on their medication. A lot of these patients are treated in the community by GPs like UChemy, but a good portion of them have gone through a bone health clinic, and so most services have a bone health clinician that can advise on the best type of treatment, or well, treatment first and the interval for repeating the DEXA scans.
Well, what I would say, almost as a challenge to you, is that in primary care, what we find is that the interval is dictated. So it doesn't feel as though there's any choice in the matter. And obviously, the person making that decision, is there room for a patient who is concerned? That there's going to be all types of patients. There are going to be those who are very proactive and are out there loading their bone, resistance training, and really overhauling their diet, their vitamin D exposure, and they know they've put in a lot and they don't want to have to wait 3 years to see what their bone density is doing. What would be your thoughts or approach to that scenario?
That's a tricky one, because the guidelines for these type of tests are set locally, and it will vary across the country. Depends on trusts, or the hospital trusts, or group of hospitals that work together, and that these things are commissioned. And I'm sure that, if we go down to our neighbors here, what they do will be slightly different. And the other side of it is, I'm a radiologist, and in a lot of hospitals, these tests aren't actually run through radiology. It's rheumatology or different departments that do it. So it's very, very difficult. And I think if we have to go back to the evidence, and I think the reason why the interval is sort of 2 to 3 years is that's just based on a lot of evidence of what is the optimum time. And actually, you don't gain anything by doing it sooner unless someone is in their specific severe scenarios. So whilst I understand patients might be anxious or want to know, and we're of an age now that, you just want to know things quickly.
Biology doesn't work to our schedule, does it?
Yeah, biology doesn't quite work like that. And so I think it's just best to just follow what the evidence shows at the optimum time, because you might just be, I know it's a very low dose X-ray, but it's still an X-ray dose. So it's best to wait and then give your body time to then improve.
So with all the scans and imaging that you see, and in a job role that's quite sedentary, does this ever make you pause and think about your bone health?
It does. It does. And so I try to make every effort to to walk around as much as I can. My job it is sort of half sedentary and half, I'm standing up a little bit. But when I have days when I'm sitting reporting all the time, then I have a desk that goes up and down. So I get up, and my helpful Apple Watch, but there are other smartwatches available.
Other providers of digital watches available.
Yes. Remind me, so I always know when it's 10 to the hour, because a little thing goes off in my arm, and then okay, get up and walk around. So that, in doing some exercise, doing some impact training and exercise. So it's really important too, especially as we get older. So yep. I think it's something that everyone should consider. A sedentary lifestyle is just not, you will not reap the benefits of it later in life.
What are the common fracture patterns? We know where the common sites of fractures are, but compared to if, say, a young fit person broke something, is there a significant difference in the fracture patterns that you see when you're reporting with osteoporosis?
The pattern, well, it's a site really, not the sort of type of fracture. So typically the most common are they're vertebral fractures that we see, but also around the groin areas of the pubic rami, and then the back of the hip. So those are very odd. So for a young person to fracture their vertebra, it's usually a really high impact trauma, but in people with osteoporosis, it really doesn't take much. And that's actually why it's really important to diagnose osteoporosis once you see one vertebral fracture, because the presence of one vertebral fracture means that your risk of a second one actually is tenfold. So picking it up from one, you need to spot it, diagnose it, and treat it, because you want to avoid getting a fracture of the hips, a fracture of the neck or femur, because once you do have that actually significantly increases your morbidity and mortality. So those are the sort of things, but it's generally the fractures of the spine, and then the front of the pelvis, the back of the pelvis, and around the neck or femur.
We know that DEXA scans are the gold standard. Is there ever a situation where someone isn't suitable to have a DEXA scan, or they can't have a DEXA scan?
Yes, there are. So if you've had hip replacements, because what the DEXA does, and the T-scores actually are really based on the scoring around your hip joint. And the DEXA looks at the density around your hip bone and also your spine. So if you've had bilateral hip replacements, then you can't really measure it. So what we tend to do is to image around your wrist bones to see what the density is there. So that can be very useful. Sometimes DEXA has some limitations. For example, in getting the mineral density of your back, if you've got really bad arthritis of your back, lots of wear and tear, you get extra bone formation around it, and that can give you a false higher reading than it should be. So when you're interpreting the DEXA, go
Because
on.
the new bone that's forming is nature's way of trying to stabilize your spine. So it's harder, it's more
Exactly.
sclerotic,
Yeah.
isn't it? So it's more dense. And
Yes.
so it gives an overall picture of the area being more dense than it is.
Then it is. Yeah. So when you're reading the DEXA and seeing the readout from the machine, it's important just to first look, okay, what does the spine look like? And you get a measurement for, although it's fine, a T-score of minus 2.5, but you'll see what the reading is for every single level. And if one level is really, really high and there's an outlier, maybe that isn't quite right. Let's get the average of the other ones. That's what you need to consider with DEXA. Also, calcification of arteries. You've got a major artery in the abdominal cavity. If you've got what's called atherosclerosis, so furring of the artery and calcification around it, that can give you a falsely higher reading. So those need to be borne into consideration when interpreting it. So if you are unfortunately someone with lots of wear and tear in your back, you've got lots of calcification in your aorta, which is the main artery in your abdomen, you've got bilateral hip replacements, then actually DEXA scan will be really, really difficult. And then you need a bit of a pragmatic approach to it. First, if you've had a fragility fracture in the past, then the diagnosis is there, and it may just be that, okay, what your primary DEXA scan is your baseline. You can just take that as a baseline, ignoring what the actual value is, and what you're looking for is a trend when you treat. Mm-hmm. That could be one way. There are other ways of measuring bone density. So you can do it with CT scanning. So there's special programs you can have within your CT scanner just to see what the bone density is. Obviously, a CT scan is a much higher radiation dose, so you wouldn't be pushing to do a CT scan to diagnose it.
If you're saying a DEXA scan is a fraction of an X-ray, then if you compare a DEXA scan to a CT scan, you're almost irradiating someone to get their bone density.
Yeah, it's a lot. But if you happen to have had a CT scan for something else, then it could be a useful tool to extrapolate what the bone mineral density is. So, that's we have that in our back pocket.
I know that you are an incredibly intelligent and talented medic. I've known you for a long time. You previously were a medical doctor, a physician, and you're someone who throws yourself into what you do. You've been the departmental lead in your locality. What's next for you in your career? As a woman who's in medicine and making waves. What do you have any projects or anything that you'd like to share with us?
Thanks for for the accolades, Kevin. So yeah, life has been busy, and medicine has been busy. I'm fortunate, as you said, to have been clinical lead for my department for a few years, and also led our governance. Right now, I'm in charge of education for our radiology resident doctors in my hospital. So which is great, and I'm enjoying that. We've just had a new intake of doctors yesterday. But beyond that, I really am passionate about diagnostics and access to diagnostics for everybody. My background is Nigeria, and I lived there as a child. So my passion is to take what I've learned in my nearly 10 years as a consultant radiologist to Nigeria, to play my part in helping bring high quality and a high standard of diagnostics to Nigeria. I've embarked on a project in Abuja in setting up a diagnostic imaging center there.
And
With some
Abuja's the
help.
capital, isn't it?
Yeah, it's a capital city of Nigeria. So excited about it. It's a huge project, but I'm really happy to have had a group of radiologists in the UK who are also Nigerian, who are keen to get involved. So they will do a lot of the reporting, because the reality is people that have the funds, they travel a lot out of the country to get their diagnostics, and people that don't are there. And it's not that there aren't any good medical facilities there, but it's just actually where's the standard. So I want to do my part in bringing the high quality and high standard of diagnostics to the country. So that's what I've been doing.
That's incredible. How far you've come, in the concepts, the infrastructure, and I'm looking forward to my private suite where I can come and maybe talk to some people about their bone health. Interestingly, do you see any variations in scans, bone density between different ethnicities at all?
That's an interesting question. Generally, looking at scans, there's no real difference. But I think based on ethnicity and where you live, I think it's ethnicity and environment.
And
Different countries
lifestyle,
have and
diet,
lifestyle and all of that. Yes, that varies. So I think in generally looking at the incidence of osteoporosis, for example, in the United States, and the epidemiology of that will be slightly different to what we have here in the United Kingdom, and also in sub-Saharan Africa. So I haven't really sat to sort of look at the numbers, but I do know that it does vary based on ethnicity, geography, and lifestyle.
I mean, the textbooks and research will tell you that Caucasian and maybe South Asian populations are more at risk. But I guess when you're reporting on scans, you're not necessarily factoring in what's his ethnicity of this person. You're reporting on what you see before you. But I just thought that was something that might be interesting to note. I just have to say thank you once again, Dr. Thahal, for coming on here to share your knowledge and experience with our listeners. Thank you. If you would like to follow Dr. Adzira Thahal's pioneering project and the incredible progress being made, please visit her Instagram account at keyimaging_. Often called a silent disease, most people don't know they have osteoporosis until a fracture happens. 1 in 3 women and 1 in 5 men over the age of 50 will sustain an osteoporotic fracture. Therefore, screening of those at risk is important. Bone density scans, or DEXA scans as they are known, are the gold standard recommended by NICE in the UK. Early diagnosis is key to preventing fractures, disability, and even early death. Early detection of osteoporosis matters. A simple painless bone scan can give you a snapshot of your bone strength. If you're over 50, postmenopausal, or have other risk factors, talk to your doctor about getting checked. Knowing your bone density today can help you avoid fractures tomorrow. Thank you for joining us today on the Joint Care Podcast, your trusted source for reliable information on bone and muscle health. As a GP with over a decade of experience in orthopedic surgery, my passion is to provide you with accurate and practical advice to help you maintain your bone health, and in doing so, a quality of life which will help you to continue independent living long into the future. If you enjoyed this podcast and learned something new today, or if you know someone who might benefit from a bone scan, please share this episode. Stay well, stay strong, and take care of your bones.